Christian, I'll turn it back over to you, I think, as we move on to the census tracts by rural geography data, and let you take it from there.
Well, thanks for that. I think Dr. Cole is going to close out that last topic with kind of a 2-minute on the last topic, and then we're going to move into the next thing from there.
I just thought it might be helpful, the topic of data management. It's health information, actually, that we're dealing with, where it has a lot of restrictions. We have assets within the state. Health Sciences South Carolina is partnered with SkyX. They already have the infrastructure and the ground level ability to deploy. I think we just need to leverage it, in my opinion. So I just wanted to throw that out there.
Yeah, and we had a phenomenal meeting, Dr. Duvey and myself today, with Health Sciences South Carolina, talking about how they can help us. And with data management, one of the things that is a challenge, and Dr. Cole has talked about it, if you get test results and they sit for a while or you can't act on them, they're not valuable. And we have over 100 labs that report their results to DHEC. And if we can streamline that process, not only getting to us, but getting that information out to the providers, it's going to make South Carolina even better and give us more tools. So Health Sciences South Carolina is a great asset.
And I would say if there is some kind of regulatory impediment there that exists, those are the type of things that we want to move obstacles, break down impediments to be able to do that. So on recommending things, those types of recommendations are good.
Okay. And I'm going to call on DaCosta to introduce her partner.
Thank you so much. We had a meeting with DHEC a few weeks ago to talk about ways to get information out into the community, how the commission could help them penetrate the minority communities, getting information about services and things of that nature to folks who are isolated. And I asked my research folks, headed by Dr. Cody Carter, to come up with a map to target those areas. We feel that if we target the areas, we can have a better handle on how we get information out to folks, and also as far as tracking or gathering new data on what we can do to improve services going into rural areas. With that in mind, I'm going to turn it over to Dr. Cody Carter, who will tell us about the maps that he has placed on the screen.
Good afternoon. I'm Dr. Cody Carter, and I'm the Director of Research and Planning here at the Commission. And in the maps I show you here that I'm sharing, they should be visible on the screen.
They are.
To the left, you see COVID case quintiles, capita COVID-19 cases. And on the right, in that map, you'll see COVID death quintiles. So the deaths per 100,000. So what I've done with the data is collect 616 counties in 7 southeastern states. So as far west as Mississippi and as far north as Tennessee, North Carolina. So across those 10 counties, Clarendon County, high quintile for COVID cases, Lee County and Kershaw County are in the high quintile for COVID cases. And the reason it's so important to do a per capita measure is because you can control for the population. Because naturally, in your more urban areas, in a Columbia, in an Atlanta, in a Charlotte, you're going to have more raw cases. Your raw number is going to be higher. But when you control for the population, you can see how it may disproportionately affect places with smaller populations. And if I select it out right here in the dashboard, you can see Clarendon County, Kershaw County, and Lee counties highlighted. And these are all rural counties according to population density across those counties. So Dr. Costa mentioned earlier that we try to target areas with high minority populations. So what I did with this dashboard, is I built into it a filter where you can see where your minority populations are concentrated. So in this filter, right here for minority racial composition, I'm going to filter out communities that are 70 to 89% African American in these communities. And this is called minority identifiable. So in Kershaw County, you don't have any communities that are 70 to 89% minority, but you do have that case in Bishopville. And Ms. Davis also mentioned how minorities are concentrated in certain parts of town. And you can actually see this in Bishopville. And some of it depends on how your census tracts are drawn, but according to this, you can see that your minorities are concentrated southeast or below South Main Street in Bishopville. So you can actually be able to, using this data, pinpoint possible locations where you can mobilize around these issues. Similarly, you have a spatial concentration here in Clarendon County. So you can see that on the western side of I-95 here in Somerton, you have a census tract that is minority identifiable. You can also see the same pattern here in Manning, in this particular area. And then I will point to something else. Now, in the data that I've recorded, across these 616 counties, there are still 8 counties which haven't actually reported any cases of COVID-19. What's interesting about these 8 counties is that 7 of the 8 don't have any hospital beds, which indicates that the reporting for COVID is not an issue of it not being present in these places, but it's rather an issue of access, healthcare access in these places. So I have another cross tab where I tried to pinpoint areas that were rural and had low access. So what you see here is all of the rural counties are selected out. Now what I'm doing here is filtering out your counties that don't have any hospital beds. So you have McCormick County, Saluda County, Bamberg and Barnwell counties, Calhoun County, and Marlboro County. Now, what makes these counties particularly pertinent for what we do is that in the city of McCormick, you have a 54% African-American population, though the county itself is not majority African-American. The city of McCormick itself is African-American. And in data I previously collected earlier in April, because I try to track it at least once a week using the New York Times data hub for each of the counties. McCormick County, though it didn't have a high per capita case rate in terms of deaths, in the map I have on the right side, the previous map, it was considered high when compared to the whole region. Now, Saluda County is interesting because you have it actually has the highest per capita Hispanic population in the state at about 16%. Now, what I can do here, not only are we looking at counties with no hospital beds, but if I do this filter for Hispanic population and I select out the census tracts with a high proportion of Hispanic residents, you can actually go in and see where your Hispanic residents are concentrated in Saluda County. So Saluda County is another interesting place. Now, Marlboro County is another one that doesn't have hospital beds. What makes Marlboro County particularly pertinent to our organization is that Marlboro County has the highest per capita population of Native Americans. So within Marlboro County, if I do this filter for high proportion of Native Americans, you can see particular places where you can actually find your concentrations of Native Americans. So you can figure out places where you can actually set up shop and be able to reach these populations if you zoom in and try to look for the incorporated areas within the county. 'County. Calhoun County is another county that's not necessarily majority African American, but when you look at the city of St. Matthews, very similar to the case in McCormick, South Carolina, is that you have a majority African American town. And similar situation as that of McCormick with COVID deaths in proportion to the population. In data collected earlier this month, Calhoun County was another that was affected disproportionately by COVID deaths. And as I was saying earlier, in these rural areas, you can miss the effects on the population because the raw numbers are not going to be high, but doing these per capita measures actually allows me to pinpoint which counties are most at risk. And though I'm looking at it at the census tract level, this still allows you to see where they are in the county, how the county compares to the whole region. So I'll clear out this filter. And I'll show another filter. Now, this particular filter shows your counties that are considered rural and have the lowest access to physicians. So you have Saluda County and you have Calhoun County, and it makes sense because these counties lack hospital beds. So you would expect them to have the lowest physician access. But as I mentioned earlier, Calhoun County, the city of St. Matthews is majority African American. So you would assume, based on the statistics, the aggregate statistics across the state of African Americans being disproportionately affected, that your African American population in Calhoun County is going to be disproportionately affected. In addition, Hispanic populations are disproportionately affected. So using that filter one more time, you can assume that these are the areas within Saluda County where you can look to try to reach these groups that may be disproportionately affected. Okay. I don't want to go too deep into it. I just wanted to hit the high points. If anybody wants me to look at any particular thing, but I'll show one more thing within this. So pointing back to your counties that are in the highest and high quintiles in terms of COVID-19 cases, I also have a filter for socioeconomic status. And the way I computed socioeconomic status was I ranked all 1,082 census tracts based on child poverty, median income, and the percentage of residents aged 25 and over who don't have high school diplomas. And so within there, I showed you racial composition. I can also show socioeconomic composition within these places. So you can see, and this is the highest level of socioeconomic distress. So you can see in Clarendon County, these are the areas that are most socioeconomically distressed. Now, these two areas are minority identifiable communities, and this is not such. And then you can see the same thing here in Lee County. The two counties that are of the highest, or the two census tracts that are of the highest socioeconomic distress level, are also minority identifiable communities. And this is not so much the case in Kershaw County that you have that racial composition. Okay, so if anybody has any questions, feel free to ask.
Dr. Cody, this is James Burns. I would just ask, to the extent that you have this data that you've collected in these maps, is there a way that this is shared with other state agencies so that they have an understanding of the issues that are affecting these communities, and so that from a, as they're looking at resources and those kinds of things, that they can see this data and they have this kind of real time, that they can work within their state agencies to appropriately respond to issues?
Yes, it's actually available on Tableau Public, and I can get Dr. DaCosta to share the link to these visualizations. the biggest limitation with the data collection is that the data is always a day behind. And it's also helped collecting data across the Southeast because I can see holes in the data across days. So I have another data set in which I compare the number of new cases per day or the number of new deaths per day. And what I noticed in Georgia was an issue of reporting on one particular date. So it should either, day by day, it should either be 0 or the number of new cases or new deaths should either be 0 or it should be a positive number. What I noticed in Georgia, and I also noticed it in Tennessee, was that on 2 particular days, there were negative numbers of either cases or deaths. So there's been an issue not only of a lag in getting the data, because this data is actually from the 26th. It's not up to date, 2 days behind, but also just reporting because everybody has something different. It's just a consistency of the data.
But we do share
So,
all
yes,
of our data with any
go
state
ahead.
agency.
Okay.
All state agencies.
No, that's good to know, because I think ultimately, as you look at how you respond to these things, and as you look longer term, I think we've heard people talk about identifying, hey, where a hotspot area may be and how you can, appropriately address those issues. Obviously, data sharing is critical to the kind of the decision-making process. So I'll turn it back over to Christian. Sorry.
Thanks. Do we have more to cover on this topic?
That's it.
First, or? Well, that's helpful, I think, and sorry, one more?
Did somebody have a comment?
I thought there was a hand.
Bill?
Just real quick, as I mentioned earlier about our 4 working groups across the universities and Prisma, Dr. Bill, I know you know Dr. Nolan, Litwin, and Osman. They've created their own, across the university, they've created their own public health task force. And they're there. They actually asked me to make sure I told you they'll be leveraged, and they'll be emailing you. Just a heads up, it's coming. As you talk about preventing the spread and the epidemiology side, our working group is already working with DHEC and also CDC around real-time tracking of healthcare system capacity. And the reason I bring that up, James, is we're not starting from 0. For the last 6 weeks, we've been working hard as groups. So under Dr. Cole's leadership, and again, the other college presidents, and Prisma, Marco Holla, we've been really hard at this. So I would stress that we need to ensure this group, as you move forward, is leveraging, Dr. Tooney, those expertise. The other thing, as you look about testing capacity, currently U of SC, University of South Carolina, Prisma, and Clemson are already working on neighborhood level tracking of outbreaks. So we've got a group that's already working through that, but also as Dr. Cole and his team on telehealth, and also University of South Carolina, we've already got a team working on telehealth models and technology. As you expand out the primary care to the rural areas, we have teams working on that already. So again, Dr. Tooney, we need to talk and get these people in the room, because 6 weeks worth of work, we're having a lot of, I think Dr. Cole would say we're having a lot of success when you bring all that brain power together across those 4 entities. So I just stress to the chairman that we ensure that we leverage that as we go forward again. So.
I would just echo that we've got a lot of resource. We need to leverage it. We need it aligned to have the biggest impact. And I think people are doing that. We just need to continue down that path. One other thought, and thank you for that informative analysis on the map. I think one thing, I spoke earlier about leading indicators. I think it's more appropriate to understand that we don't actually have good leading indicators. What we have is lagging indicators of this process, which means that it's 2 weeks for us to see the impact of any actions that we take or not. So until we can get better indicators, it's like being in a slow motion prize fight. In fact, you have to take 3 hits before you can hit back. So I think it's important to understand that so that we take measured and thoughtful things and act. I'm not saying that we don't do anything. I'm just trying to point out the reality of sort of the frustrating reality of where we are in terms of data management, data informatics. I don't know, Dr. Bell or anybody, I assume you'd agree.
I certainly agree that real-time data is absolutely necessary for us to be optimally responsive. But I also want everyone to understand with what we do with what we're receiving. So all COVID-19 cases are required to be reported to DHEC by a provider or a laboratory. And each and every case that we receive, once we get that positive report, is investigated by our EPI staff. A case report form is completed so that we're collecting date of onset of symptoms if available. That's a problem for people who are asymptomatic. The date that the test was performed, and all demographic information if the individuals are willing and well enough to complete that information. So there is an immediate response. This is immediately reportable in South Carolina to the investigation of each case. And then some sort of contact investigation is conducted around each case. We are prioritizing the cases because we want to make sure that the contact investigations around those at highest risk of spreading to others are our highest priority. And we also engage the individuals who are infected, giving them information to inform their contacts about measures that they need to take to prevent the spread. So I did just want to make it clear that there is an electronic database in South Carolina that captures 100% of the cases when they come to our attention. I do agree that there have been lags in reference labs outside of the state in reporting some of those, and so there were some delays. But I just wasn't sure if that was clear to everyone. But we also recognize that we're not testing everyone, and that's an important thing that's missing. We're responding to the information that we get. We have asked healthcare providers, initially, as many of you are aware, because of limitations in testing supplies, we were asking to prioritize testing for those who are most ill. And so we recognize that those early numbers, what we're missing is the people who are in the community weren't sick enough to seek hospitalization, and so that is what we're working towards to get a better capture of people who are less ill in the community, and more and the electronic exchanges, so that the rapid transmission of electronic laboratory reports from healthcare facilities to our electronic database is something that we certainly want to enhance, because there are many rural providers who are still submitting information on paper forms, and then our staff have to enter that into the electronic database. So there are many opportunities for improvement.
Just to be clear, I was actually assuming that we had perfect reporting. What I was trying to say in terms of lagging indicators is that if there's an event, it takes 2 weeks for it to show up.
Yes.
Right? So if there's a bad moment in a Walmart and 100 people are exposed, it's 2 weeks until we actually see the infection, and for us to react to it, we're now 2 weeks behind, and it'll be another 2 weeks before we see the actions of our actions.
Yes.
That's what I'm talking about in terms of lagging indicators. So it's a slow motion thing, and it's very, so that's what I was trying to point out.
Yeah.
It's critical that we report and act as quickly as we can, but I'm just pointing out that the infection and the actual test is 2 weeks old, right? That's hard. That's hard. I mean, I wish the dynamics are different, but that's the way it is. So we have to acknowledge that. I'm just trying to point out, just acknowledge. We need to understand that. So when new businesses open up and they think, and we give them the best advice and we're doing the best things we can, it's going to be 2 to 3 weeks before we actually even know whether it's being done properly. And if we adjust, it'll be another 2 to 3 weeks before we see the effect of that, or not. So
I like to compare this to treating somebody with high blood pressure. As a physician, if a patient comes to me with high blood pressure, I might start a medication. If the next day I see the patient and the patient continues to have high blood pressure, and I assume that my medication has failed and I start another medication, then I could be doing harm. But if I don't have the patient come back, I may never know if my blood pressure medication has worked. If we want to see the effects of what we do, we have to give it time to work, and then we have to continue to check in and see how has that patient's blood pressure responded. In 2 weeks, come back. If it hasn't responded, then I do more. I may add another medication. I may change the medication. Probably I'll add another medication. And then I have the patient come back in 2 weeks, and we check again. So with many things we do in medicine, the end game doesn't happen immediately. We need to continue to monitor, and we need to continue to respond. And I think that it's a nice parallel with this. We know that if you're exposed to COVID-19, it may take 5 days for you to, if you are going to exhibit symptoms, to develop those symptoms. Your symptoms initially may be really mild. You may start out with a sinus headache or a sore throat, and you may not think that you have COVID, so you may not seek medical care. By the time your symptoms get severe, it may be 5 to 6 days later. You may seek medical care, you may get tested, or you may not. So I think that's what Dr. Cole is saying, that it's a process, it takes time, it has to play out over time before we know what the results of the actions we take today are. And if we try to do too many things at one time, then we may never know what didn't work and what did work. And so when we're monitoring, you know, so for example, in this, I'm not suggesting we should do this, and I'm not suggesting that the governor would do this. If we threw open the economy, we wouldn't know. We wouldn't know, was it, you know, the retail? Was it having everybody eat, you know, go to restaurants? Was it having people go to the bar? Was it having your hair cut, which I need desperately? We would not know. So I think a measured approach, as the governor has taken, gives us the time, really, to understand the impacts of every measured incremental change. And so I appreciate that as a physician. That's really how we practice as physicians.
And I also would add that the importance of relying on other surveillance indicators besides the performance of tests. So there are ways to get a bit more real-time data if we monitor for syndromes that are consistent with the infection, influenza-like illnesses, or now COVID-like illnesses. So to conduct syndromic surveillance that we can see immediately from ER visits and things like that don't rely on the results of a test. And so there are other surveillance indicators that we can also monitor. There are great stories historically of outbreaks in communities of, for example, gastrointestinal illness, and there were no antidiarrheal medicines on the shelves in pharmacies that were purchased over the counter, and that was one of the indicators that there was a widespread outbreak that had not been recognized through testing. So we of course can't do that kind of surveillance now in the absence of a drug, but there are multiple other means of doing surveillance that is additional data.
I think Director Baker had something too.
I think I would actually thank Dr. Bell for sort of putting my comment in there before I did pretty quickly, which is, you know, there are some tools that the Medicaid agency has used for years to predict the presence of chronic disease. And given the correlation between chronic disease and ill outcomes with this virus, I think what we would say is things like the Small Area Deprivation Index, where we have high-risk individuals, known but limited known presence of the virus in the community, but also an understanding that there's marginal attachment in some cases to the healthcare apparatus. That's something we use for risk stratification and setting MCO rates can be overlaid with real-time surveillance data. So to Dr. Cole's point and Dr. Bell's point, there is tremendous data and infrastructure that we've published against that, using existing linkages, we can perform some of those surveillance without having to create new linkages or new infrastructure or new analyses that can be shared with DHEC, and that's just something that would have stayed buried inside the Medicaid apparatus throughout this. Had we not had these conversations, I think back to the governor's charter, though, making forward-looking recommendations with data we know to be dated, I think accepting the limitation of what is available to us, but knowing where we don't have a complete picture, is something that I do finance. So we can finance HSSC and SkyX to plus up the infrastructure. Between the Medicaid agency and Blue Cross, we are the largest payers in the states in terms of incenting private labs. To a comment Dr. Cole made during the break, how do we know that these labs are providing high quality services, and how do we ensure compliance with reporting? The answer is the payers is as much as the regulators. So I think from a payer standpoint, we're asking, put us in, coach, right? Let us use our data and let us use our influence to get the healthcare providers, even if they're not in state or part of the hospital systems, to come to the table and report the way they need to.
Excellent.
Yeah, it's a great.
Excellent.
Thank you.
Well, I think we never formally transitioned, I think, into this agenda topic, right? But we very clearly have moved ourselves into the responding to new cases category. And a number of the things that we've talked about, really, I think, before the break and then in the time since, fit pretty well into that space. We've talked a lot about, contact tracing in particular and sort of, the existing approach, obviously. And I think the expectation that there will be additional requirements above and beyond what exists today. I mean, obviously it is difficult on the fly to figure out how to quantify those kinds of things. And I think, as you talk through this in the next moment or two, we're not the only task force that's part of this larger undertaking with AccelerateSC, right? I mean, there's another committee that will meet later this week that is going to focus on, resources and the sort of the financial requirements of the response. But I think, we're here to talk about, what some recommendations might look like on the protection front. Some of those things are going to be what we just talked about in the last few minutes, right? There's a number of places where it's been pretty clear for the last couple of hours what the wisdom is of bringing this combination of people together, which is that each of us have some kind of component, some portion of the overall response that we're responsible for, and we don't always, when acting independently, brush up against each other in the right combinations to get some of these things done. And bringing us together through AccelerateSC is going to help us follow up in the appropriate way and in ways that we might not have otherwise done. As you think about what additional resources are going to be necessary to get a more comprehensive contact tracing or one that's just able to reach further into the community over the course of the next few weeks and months, one, I think we want to make sure that we talk here about what the right recommendations might be. But two, I think we want to make sure that we also get those thoughts and at least some kind of a rough price tag in front of that resources committee as well, so that we can make sure that we're not just working together collectively here as the protection group, but that the protection group is also working with the resources group inside of AccelerateSC to make sure that if we have ideas and we have recommendations, that we can come back to the appropriate decision makers to give them a sense of what exactly it is that we're asking for. So do you want to talk some more then about where you think contact tracing might go in the coming weeks?
Yeah, absolutely. So one of the things we do know about COVID-19 is that you can't get it if you don't come in contact with it. So if we know that 50% of cases are asymptomatic, and we know that a large majority of cases don't ever seek medical care because their symptoms are mild and they're managing them at home, and maybe they're afraid to go to the emergency department because they don't feel that they have COVID and they don't want to get it, we know that most people are not getting tested. So when we do find people who are tested and who are positive, we really need to consider that a Sentinel case. And by that I mean that we need to look at that individual and very carefully understand where that person has been, who that person has been in touch with, and expand the contact tracing that we do to include every person who's diagnosed, not just those with serious illness, not just those living in congregate facilities, but every person who is diagnosed, so that we can then reach out and test and talk with every person they've been in contact with. And as you can imagine, people who don't know they're sick are maybe in contact with a large number of people. That seems like a daunting task, and I think it is. But I think we need to ramp up so that we can get there, because if we truly want to stamp this out, we need to be able to identify those who are asymptomatic. And honestly, unless we test the entire population on a regular basis, which is very impractical, the only way to really get there is to do that intense contact tracing. Every person who tests positive, every contact. They're starting to do this in states like Massachusetts, where they have an all-out effort and have trained thousands of contact tracers to work around the state. And I think we can get there. I think it's still, we're still talking about what this looks like, we're talking about who those partners will be. We've had some great suggestions, working with furloughed medical staff, working with our healthcare students. I know that there are some young medical students who haven't been able to be on their usual rotations, who are kind of chomping at the bit to get some hands-on experience. By hands-on, I mean it could be phone contact, not necessarily face-to-face. But there are a lot of opportunities around the state to work with people who are interested. I just read an article from the University of Southern Florida that said that their faculty and staff are actually volunteering to contact trace in other states. So they are so interested in contact tracing that they're willing to contact trace outside the state of Florida. I can only imagine that we'll find this degree of enthusiasm. I came from a university setting, and before I left, we were able to sign up 90 of our public health students to help the State Department of Health in Indiana to answer their phone lines and help with contact tracing. That's, one school of public health in the state of Indiana, and I was one person. So imagine if we force multiply that, how many resources we'll have across the state. It's just going to take coordination. It's going to take coming up with a plan to do this and to do it effectively. How do we get them trained? We certainly don't want to bring them all into a space to do training. We use tools like Zoom to do face-to-face training, which is really remote face-to-face training. Who does the training? That's something that we'll need to answer. We have I think 130 contact tracers now at DHEC, and we have some who've been doing this for quite a while. We can look to our TB staff, to our HIV staff, who routinely do contact tracing to help us get this new workforce up and ready to go. I think it's very important, critically important, to include contact tracers from the community, people who are trusted members of the community. It's one of the things that we learned during our HIV outbreak in Indiana, was that the contact tracers who were trusted members of the community were able to get information from people who would, if I were to go and ask them questions, probably refuse to even talk to me. So how do we engage trusted members of the community so that people are not afraid? Undocumented individuals may be afraid to talk to people who they don't know, who they don't trust. So I think that's going to be something that's critically important for us to consider when we're bringing on this workforce to help us with contact tracing. So testing, continue to test. I think we need to expand testing to include anybody with symptoms. And I do want to highlight that, for so long we've been talking about symptoms. If you have a fever, if you have a cough, if you have shortness of breath, what do we know now about those symptoms? We know that those symptoms are very late in the game, that many people never develop that severity of symptom. And I've read from emergency physicians across the country about people who have oxygen levels that are next to death, but they're sitting there talking to people on their cell phones. They're not typical. They don't present in a typical way. So I think we have to be very careful about, saying if you have a fever, if you have a cough, if you have shortness of breath, because we know that a lot of people have headaches. They have fatigue. They might have chills, but no fever. They have a sore throat. They may have a little bit of a dry cough. They may develop that cough late in the game, at which point they will probably end up hospitalized at some point. So getting the word out that there are milder presentations of this illness, but we still need to make sure that we get you tested so that we can do that contact tracing and identify those individuals who may not have symptoms. Very critical. And then I wanted to say a word about evening out at those peaks that we see in the daily reports, based on when we at DHEC get those tests. Public health agencies can only report what they have in their hands. We can't report information that we don't have. So I think the electronic transfer of information becomes critical in a pandemic like this. But I will say that there will be glitches outside of that electronic transport. It could be that our system is down. It could be that, I don't know, there's somebody who's not participating in that electronic system. So I think that we will always see those daily surges, not daily, but we will see them routinely every once in a while. So how then might we even out that information? For example, when DHEC had a shortage of testing supplies, we had a significant backlog in the number of tests. So when we reported those tests, it wasn't that all those individuals had been actually swabbed the day before. They had been swabbed over a period of time. In public health, what's of most interest to us is not when we get the information and when we report the information, but when the critical event occurred. So what we have decided that we would do with our online reporting is that we will attribute cases to the day when the test was drawn. So when we see the data online, we're not going to continue to see those peaks where we have 70 tests that came in one day because somebody didn't report to us, and these are 2 weeks old. We'll attribute those to the day the test was done. And what that should help do visually is even out that curve as we report that online. So I would just like to highlight the importance of contact tracing. I think this is something that in many countries has not gone away. They do active contact tracing around a lot of outbreaks. It's how we got rid of smallpox. And I think we need to go back to our public health roots, really, when we're thinking about this, and establish a vigorous system of testing and contact tracing so that we can continue to hotspot and put out the fires that we see emerge periodically.
So if I could ask Director Toomey a question. So you said, as I understood it, Dr. Toomey, you've got 130 contact tracers at DHEC, correct? Is that correct? So what is the time period? Like you talked about, like, hey, if you try to plus up contact tracing in the state, what's the time frame to train up these people? I mean, is it a matter of weeks? Is it a matter of months? Is it, if you could briefly just touch on, like, what's the time frame to train people up in this?
So I think that the biggest time commitment is going to be developing the training capacity and identifying the contact tracers. That once we do identify people who can do contact tracing, and Dr. Bell can speak more eloquently about this because she's familiar with the forms that need to be completed, but it is a matter of asking questions and entering data. There may be training around the way you ask the questions, of course confidentiality training, but I'm going to let you speak to how long you think it might take to train the technicalities.
Yeah, the training itself shouldn't take a lot. And I would agree with Dr. Duvey. It would be identifying the people who could come from various backgrounds. But if you're using healthcare workers who are accustomed to taking a medical history, it would be very simple for them to complete this form. We're using disease investigators, social workers, people who work in WIC who are just accustomed to working with clients and asking these questions and have the interview skills. The point being made about trusted individuals, so we may draw on community health workers who might not necessarily be familiar with this component, but it's important for them to get the skills because those are the individuals that the community members, those who are contacts, would speak to. So there's another level of skill in collecting potentially sensitive information, but it would be having some sort of standardized training that was developed. I think Director Toomey mentioned a contact investigation academy or something like that. So in order to train a large number of people in a short period of time, it's the logistics of doing that, but not the training itself. So if we could figure out a way to identify the people, students in schools of public health would be ideal, teachers, all sorts of members who would just get some sort of standardized training to collect the basic information. The training itself is not that complicated. It's just finding a way to do it with a large number of people. And I'd note that I think in the state of Florida, they said that they engaged over 100 or so workers over a weekend to begin assisting with contact investigation. So it's just finding the workforce. The training itself should be simple.
If I might add, I would strongly endorse the contact tracing dimension. I would say that the workforce is there. It's not a matter of identifying the workforce. We have education system that's out of work for the time frame that we need them. We have a lot of healthcare workers across different health systems across the entire state. It's a matter of engaging.
You're right.
And every conversation I've had is, hallelujah, we'll be glad to help. So I would advocate if there's anything we can do to cut the red tape and to get the sort of the process improved. I personally don't think that's a mystery. As a basic concept, we need to leverage our assets. One is that workforce just sitting there, educated, capable, committed. They have as much vested interest in getting back to normal as everybody else.
Yep.
The other thing I would say is we need to leverage technology. You know, we already have work groups working on apps that can leverage what Google and Apple are putting out there that would be able to, when you show up as a high-risk individual, it can tell you who you touched and who you were around in the last 48 to 72 hours. Those things will be deployed quickly, so we need to leverage our technology, we need to leverage our personnel, and get it deployed. Last comment I'll make is until we get this up, we have to be able to respond rapidly in the hotspots as they show up. They're already showing up.
Yep.
They're already there. So I think that we need to have a short-term plan that's rapid response and then leverage our capabilities as we move forward, in my opinion. One last comment. I didn't, Lieutenant Governor, answer your question adequately. The criteria definitely need to be loosened in terms of diagnostic testing. It's like turning the dimmer switch up on your living room, right? We need to turn the light up so we can understand what's going on. Totally agree. I'll be quiet.
Yeah.
Well, and that, just follow up on the question, that's part of the equation will be resources. And as we completely identify this, it's both human resources, but there may be some technology resources that we may need to utilize. So again, as we share information across the task forces, this will be important information to share.
And we,
I would be, speaking for Dean Chandler, our public health, I would be very surprised. He would be very supportive of this. And he has a large public,
yes,
his college, Arnold School of Public Health is very large.
yeah.
And he's got a lot of students in state, all over the state. So we should have that conversation with him when you're ready.
I'm ready.
Okay.
Well, as Captain Burns knows, I grew up in a Marine Corps family, and I've been thinking for some time about, you know, all the stories my dad used to tell about 90-day wonders and folks being rushed through training in World War II. And, you know, it's becoming increasingly clear that, you know, the contact tracers are going to be the 90-day wonders of the fight against this outbreak. So it's pretty clear we're going to have some recommendations in that space, and thanks to everyone for the insight just shared on that topic. You know, the last topic we had on the agenda for today is about PPE. It's about protective equipment, and I want to thank Chuck Spangler for his patience. He's been waiting patiently as a tiny little box on the screen in front of us for a little while. You know, as we all know, this is an outbreak that began in China, where much of the protective equipment used in the United States has been manufactured. And so since January, you know, hospitals and other healthcare providers all across the country have been rushing to try to find more supply, knowing that, you know, trouble was on the horizon. And, you know, many of these healthcare providers buy through, you know, leveraging their purchasing power, right? You know, an individual hospital or nursing home generally doesn't go out and buy, you know, masks or gowns, you know, independently. They do it through these purchasing collaboratives. And folks have been what's called, you know, on allocation, you know, since January, which is basically, you know, you've been limited in terms of your ability to order more supplies to plan ahead. And so, you know, we've kind of had it through both barrels. You know, the place where these things have been manufactured for the past many years is where this all started, and so they shut down production early. And then everyone, of course, rushed, you know, to go and buy whatever was left on the market. So, you know, just as we already had, you know, practices in place to buy this material collectively in the past, there's been a collective response, you know, in the you know, the weeks since. And so Chuck will talk in a moment about how South Carolina has started at first on the healthcare side to work together to match available supplies to hospitals and nursing homes and physician offices that need this material. But it started to look more into the future about, you know, is it time to begin onshoring some of the production of some of this equipment? And, you know, and do we need to think about not just having a national stockpile going forward, but should we be thinking about a state-based stockpile as part of the long-term recommendations as well? And so with that, I wanted to throw it to Chuck Spangler. Chuck, if you're talking, we can't hear you, but I don't know if that's on your side or ours.
Sold out.
I would just in that moment, we've been having a lot of discussions, and it was pointed out to me, and I would certainly endorse it, that, to date, PPE has been focused in the healthcare setting. And we talked earlier about the fact that we've got capability, we've got capacity and so forth. I think it will be shifting to the communities and the local in terms of, how do you sort of protect with businesses and so forth. So there's going to be an ongoing need as it'll go to the communities and businesses as this moves forward. I'm just acknowledging that the focus is, there's still a need as we move forward.
I think even in the manufacturing locations, we struggled. We're trying to bring in 500,000 masks just to help support over the few months that we want to operate. And it has been a large struggle to bring in the right quality of masks in. I know globally we invested in some of our own equipment to produce our own. But I think, Christian, the topic that you brought up is that something we should not be looking as we try to, resource here within our own region? Can we not, work with industry here to help support the needs that we have moving forward? Because we are too dependent on other countries at this moment. And that's something we should be looking and trying to say, what are the lessons learned from this? How can we be better from this? And I think that's just an obvious point we should be looking at for sure.
No, and especially, given the fact that it's a state with such a, sort of a rich heritage in the textile business, you would think this would be a pretty natural place to think about, where we go from here. Yeah.
Let me just let you know one thing that we've been pretty successful with in South Carolina. One of the key components of that PPE has been face guards and eye protection. And to your point earlier is that we were able to find a producer here in South Carolina, actually here in Columbia, and we've had pretty good success getting those out there. So in the emergency management perspective, we've been able to pretty much fill all our requests and actually ship more out, but we've got that production here. And we're also looking at other capabilities here in South Carolina along those same lines where we can do that. And we're hopefully here in the next few weeks we'll have some other supply chains as well.
That's right. No, thanks for pointing that out. As you noted, there have been manufacturers here in Columbia who have started doing pretty novel things with 3D printing to help, produce face shields and other equipment that's been necessary. Earlier we talked about some of the CDC guidance about, their recommendations to the public, and, CDC's guidance has been reasonably permissive in terms of what kinds of equipment, what kinds of masking might be used in which setting. Excuse me. Let me be clear that this is an allergy problem. This is not, this is pine. This is not a broader health issue. We, I think if we're running into technology issues, I think we know we're going to be talking more over the course of the coming weeks as well. And I think, with apologies to Chuck, since we're a few minutes over time anyway, it might be appropriate, maybe to wrap today's session, and we can come back to Chuck and have another opportunity.
There it is.
Hey, can you hear me okay?
Can
you hear me okay?
Okay, we hear you better now, yes.
Can you hear me?
Oh, yeah.
There we go, full volume.
Can you hear me okay?
We can hear you now.
Maybe I should be asking the other way. Chuck, can you hear us at this point? Always do a bit of a soft shoe routine. Yeah.
Christian, I think in the interest of, maybe we can catch this just for the benefit of everybody we've got, and I'll let you close out the session. We'll certainly get the information that Chuck's provided and make sure we get it out to everybody. And then if we can catch them the next go-around.
That's right, and I think we may well just need to reschedule, Chuck, for a follow-up engagement as well. But, I know that I've been taking quite a few notes as we've been talking today. I've heard a good bit of consensus about areas for follow-up and where we need to be coming together either as a group or where different subsets of us might need to follow up on items as well. I think it's been helpful to have this combination of people brought together, and I think be very thoughtful and deliberative about what our incremental changes are going to be over time. Right? We know that our capacity to test and trace is going to grow. is going to be growing with each passing day. And so I think in association with that, we're likely to produce recommendations that are designed to sort of fit that curve, as our readiness and our ability to respond continues to improve with each passing day.
I'll turn it over to the governor. I think he's got some comments.
Well, just one. Thank you very much. It's very informative. We've had some great meetings, a lot of discussions. And we need information constantly because we have to make little decisions every day. And we can't wait till we have all the information. The perfect is the enemy of the good. And there are a lot of pressures from all sides. And a lot of desires need to be satisfied. So we thank everybody very much. It's great to have this kind of participation among so many people that are so skilled and knowledgeable and educated and experienced in these areas. So thank you.
I think with that, Dr. Toomey, you have any other comments? So for everybody within the group, and I'll send an email out today. Our next large group is, as far as the entire AccelerateSC, will meet next Tuesday from 2 to 4. And as I encourage the governance group, y'all collaborate among yourselves as you are working on this. It certainly doesn't take, me having or us saying, hey, we have to go sit down in this room to collaborate with one another to come up with good ideas and recommendations. That should be something that's ongoing because, again, we want to get the best information we can, so that we can move forward in a smart and productive way. So unless there's anything else, thank you, everybody, for your time. I would ask as we close out once again, and I'm looking at Dr. Bell and Dr. Tuvey, that we will exercise social distancing on our way out the door. So thank everybody for your time today.
Thanks again.